Hi, my name is Pierre-Olivier Dionne and I'm a cardiac surgeon at Royal Columbian Hospital in British Columbia. Welcome to the Type A aortic dissection talk for the 2021 CSTRP. The purpose of this presentation is to review the main lines of diagnosis and treatment of Type A aortic dissections. First, we'll discuss about the classifications. Then we'll touch on some of the surgical situations that you may encounter in these cases, as well as long-term considerations. In previous years, this presentation was complemented by surgical cases, but unfortunately this year, due to the COVID pandemic, these interactive cases won't be possible, but will be left in this presentation for you to review. The first case is one of a 32-year-old female who is a drug user who's being admitted for fever and bacteremia, who underwent an echocardiogram looking for endocarditis, and they had an incidental finding of a flap in the ascending aorta. The CT shows a type A aortic dissection. It's 4 in the afternoon, and you get a call from your cardiology colleagues. On this view, you can appreciate the flap in the ascending aorta. Now, the patient is hemodynamically stable. She had an episode of chest pain about 2 months ago, which brings us to the first question is, what do you want to do now? And brings us to the first topic of timing of surgery. The most commonly used timing classification uses the term acute for dissections that happened less than 2 weeks ago, subacute for dissections that happened 2 to 4 weeks ago, and chronic for dissections that happened more than a month ago. The reason why this is so important is that dissections have a very high mortality rate initially in the first couple of days, even hours, and then when we get further from the onset of the dissection, the hourly or daily mortality rate goes down quite a bit, as these patients are at that point more stable and become chronic. On this graph, one can appreciate how low the mortality rate is after a month from the initial onset of the dissection. This graph essentially communicates the same information, that the mortality rate is much higher initially, and then as the dissection becomes more chronic, this mortality rate decreases quite a bit. Aortic dissections are further classified based upon the location of the aorta that is affected by the dissection. Two main classification systems have been used: the DeBakey classification system and the Stanford classification system. The Stanford classification system is essentially divided in Stanford A and Stanford B. Stanford A characterizes any dissection that involves the ascending aorta, and Stanford type B characterizes any dissection that involves only the descending aorta. The DeBakey classification is divided in DeBakey 1, 2, and 3, the type 1 being the most frequent. DeBakey type 1 characterizes aortic dissection that involve the ascending and the descending. Type 2s involve only the ascending aorta, and type 3s involve only the descending aorta. It is fundamental that you be able to diagnose readily an aortic dissection. However, this is not the aim of this presentation, but I will take a minute to discuss a risk score that was validated thanks to the IRAD registry that divides the features that can help in diagnosis of aortic dissections in high-risk conditions, high-risk features, and high-risk physical exam findings. This was validated in about 2,600 patients from the IRAD registry. 96% were identified by one or more of these 12 markers. 59 patients had features from 2 or 3 high-risk categories. High-risk conditions that were identified included Marfan syndrome, a family history of aortic disease, known aortic valve disease, recent aortic manipulation such as coronary angiogram, and a known thoracic aneurysm. High-risk pain features included pain that involved the chest, back, abdominal cavity that were abrupt in onset, were severe, and were ripping or tearing in nature. High-risk physical exam features included a pulse deficit, a differential in systolic blood pressure, a focal neurologic deficit, a murmur of aortic insufficiency, and patients in shock. When assessing or managing a potential aortic dissection, it is fundamental to remember that perfusion to any of the organs may be jeopardized by this dissection. Case number 2 is a 55-year-old male who is hemodynamically stable, who has an uncomplicated acute type A dissection that was diagnosed by TTE and CT scan. You get a call from cardiology, you review the films, you concur that the patient does have a type A dissection that seems acute. It's 8 p.m. What is your plan? In this case, given the very high mortality rate acutely after the onset of a dissection, your answer to this question should be to take the patient to the OR as soon as possible. This brings us to the heart of this presentation regarding your surgical approach in terms of monitoring, cannulation, and extent of aortic resection. We will now discuss a few surgical situations, but first let me emphasize that the number one goal and the main principle of type A aortic surgery is to bring the patient alive out of the operating room. The first surgical step will be to determine your cannulation strategy. The goal of the cannulation is to redirect flow in the true lumen, but must be performed in a timely fashion. The first cannulation approach that will be discussed will be the right axillary cannulation, which should be the favorite approach in uncomplicated type A dissections. It has multiple advantages. First, it adds a potential for antegrade cerebral perfusion. It's an artery that is usually free of atherosclerotic disease, and it usually redirects flow in the true lumen, although this is not always the case. It has some disadvantages. There is a risk of arm overperfusion. This artery lies in proximity to the brachial plexus, therefore there can be injury to this structure. It is also less useful in urgent situations as this approach is a little more time consuming compared to a femoral cannulation approach. This picture nicely illustrates this approach, which you should be fairly familiar with at this point. On this picture, you can see that the background graft is sewn in an end-to-side manner to the axillary artery. The second cannulation approach that you should be very familiar with is the femoral approach, which has multiple advantages. It is very fast. It's readily accessible. Unfortunately, it has some disadvantages. There is a risk for embolic stroke from retrograde perfusion. There is a potentially higher risk of malperfusion to proximal organs, and there unfortunately is not the possibility of doing antegrade cerebral perfusion using this approach alone. Now, in terms of perioperative monitoring, I suggest that you should use at least radial art line, preferably the right one if you're going to do antegrade through the right axillary, as well as femoral, at least one femoral art line. That way you get a sense of the perfusion of the upper half of the body and the lower half of the body. I'd also recommend you use cerebral oximetry, as this gives you an idea of cerebral perfusion. TEE is always a good adjunct, as this can help you in assessing the level of aortic regurgitation, the localization of any wires that you may be using, as well as help in the weaning from cardiopulmonary bypass. A nasopharyngeal temperature probe is very important, and this is probably the most readily accessible temperature probe that will give you the best idea of cerebral temperature, which is what we care about the most, as well as a bladder temperature probe. I would also recommend that you wire the arterial line in case you need to recannulate, or if you decide to give selective cerebral perfusion in case you cannulated femorally. When you're initiating cardiopulmonary bypass, I recommend watching the line pressures, watching the cerebral oximetry, and you can also look at the TEE to get a better sense of flow in the true and the false lumen in the descending aorta. There are other less commonly used but valid cannulation approaches, one of them being the innominate artery. It has similar advantages to the right axillary cannulation with regards to antegrade cerebral perfusion. It does spare a second incision and the potential for injury to the brachial plexus. There is, however, the disadvantage of having to clamp an artery that is feeding the brain with the associated potential risks of stroke. Another arterial cannulation approach is direct aortic. It's a less popular approach, and it requires some kinds of ultrasound guidance, most typically TEE, and is typically done over a wire, as illustrated in this illustration. The last approach that I will touch on is the transapical approach. This approach should be reserved to emergency situation as a last resort in patients that are highly unstable. Notice that the holes of the aortic cannula should be above, ideally above the aortic valve. In conclusion, as far as arterial cannulation goes for acute aortic dissections, The approach should be ultimately guided by patient factors and surgeon preference. For the purpose of the exam, I would suggest that in stable patients, you use the right axillary artery, and in unstable patients, you use the femoral artery. The next topic I want to talk to you guys about today is brain protection in the setting of repair of an acute dissection. As you know, the brain is the most sensitive organ to hypoperfusion. We can, however, alleviate the sequelae of hypoperfusion by two general measures. The first one being hypothermia, and the second one is to minimize this hypoperfusion by using adjunct cerebral perfusion techniques. So, where should we monitor brain temperature? The sites the most reliable in monitoring the brain temperature in that they have the less variation between them and the actual brain temperature is the nasopharynx and the esophagus. There are three main different alternatives for circ arrest. The first one being deep hyperthermia circulatory arrest alone. The second one being hypothermia and antegrade cerebral perfusion, and the third one being hypothermia and retrograde cerebral perfusion alone. There are four different levels of hypothermia. I would recommend you learn this by heart for the exam. This graph nicely illustrates the proportion of patients who undergo electrocerebral silence at various levels of cooling. Here we can appreciate that very few patients reach this electrocerebral silence in the early range of the moderate hypothermia, whereas about 50% of patients do reach this electrocerebral silence at about 18 degrees nasopharyngeal temperature. This seminal paper by Dr. Grip nicely reflects the previous slides as it shows that the safe duration of hypothermia circulatory arrest alone increases when the temperature is lower, showing a rather safe duration of circulatory arrest of about 31 minutes at a nasopharyngeal temperature of 15 degrees Celsius. This nice graph again illustrates this relationship where the cooler you go, the longer the safety of hypothermia circulatory arrest. In summary, deep hypothermia circulatory arrest alone is safe for short durations of less than 40 minutes. It gives you the opportunity to work in a completely bloodless field, but the disadvantages is that since you're potentially going cooler because you're not using any adjunct cerebral perfusion techniques, you're probably going cooler, therefore you have a longer cardiopulmonary bypass run time, and you're potentially more coagulopathic post-op. Which brings me to the next topic of adjunct cerebral perfusion. Antegrade cerebral perfusion is the most commonly used approach, using the right axillary as the artery of choice. When you're using this approach, a couple things to be aware of. So the right arm overperfusion, Like I previously mentioned, I would urge you to watch the cerebral oximetry, um, and I would also, once you're circ arrested, watch for blood return from the left common carotid, which might be a good sign of bilateral brain perfusion, depending on the circle of Willis. You can also achieve this using selective perfusion cannulas that are typically balloon tipped. The flow rate should be at about 10 to 15 milliliters per kilo per minute. And this approach has the advantage of potentially prolonging the duration of a safe circulatory arrest. Another approach to cerebral perfusion is retrograde cerebral perfusion. This is accomplished using perfusion cannula to a snared SVC. This approach maintains the brain cool, potentially acts as a cooling jacket. There is uncertainty in the literature about the nutritive value of this approach. It does, however, flush out the debris and air emboli, and can also be helpful to differentiate the true lumen and false lumen, especially when head vessels are dissected. When using this approach, one should aim for a CVP of around 25 millimeters of mercury, which is usually obtained at around 200 to 300 cc's per minute, but this can be increased up to 500 cc's per minute without worrying about complications of cerebral edema. For the exam, my recommendation would be to always cool to 18 degrees Celsius. In a stable patient, I would cannulate the right axillary artery. I would always try to use integrate cerebral perfusion if possible. If, however, the patient that you were presented with was unstable, then I think cannulating the femoral artery is the safest approach. And then in that case, if you wide off the arterial line, then you still have the opportunity to perform integrate cerebral perfusion using selective integrate. I suggest that for the exam, you have your own sequence of events for type A aortic dissections. In this slide and the following one is a safe sequence of events that you can use for this purpose. Obviously, there's other ways of doing this that can be equally safe, but if you don't have a sequence of your own, you can use this. The third clinical case is a 32-year-old female with an acute type A dissection with a dissected descending aorta, so a DeBakey type 1, who presented with a left-sided stroke. You brought the patient to the OR, your axillary cannulated, you've cooled down, you've circ arrested, and now you find out that the intimal tear is actually in the arch at the greater curvature, and it's going into the left common carotid. The next question is, what will be the extent of your distal resection? When doing the distal resection in the setting of an type A dissection, it is very important to resect the site of the primary intimal tear. Therefore, this should be the main motivator to perform a more extended aortic arch resection and reconstruction. Now, the least extensive distal resection that should be performed should be a hemiarch under circulatory arrest in order to be able to put together the various layers of the dissected aorta. However, if the intimal tear goes into the aortic arch, then in order to resect this intimal tear, then a more extensive resection may be warranted. Independent to this is the clinical scenario. Therefore, if a patient is coming with malperfusion, then there is a chance that with simple surgical proximal resection and repair that the malperfusion will resolve, but there is also a chance that not that malperfusion to not all vessels will be resolved. Therefore, there is more and more a tendency to perform some kind of maneuver that can help with the malperfusion, be it a stent in the descending aorta that can be in the form of a covered stent or an uncovered stent. This will be discussed further later. These most commonly is a prefabricated branch graft with an elephant trunk. There's a fabricated branch graft with frozen elephant trunk. The E-Vita standard tubular graft with branch grafts and frozen elephant trunk. The last option, if you don't have access to any of these, would be to use branch grafts to the head vessels. The Siena graft is a very versatile graft. Can be used for 1, 2, 3, and 4 vessels arch replacement. The skirt allows for matching of the distal aorta. It has radiopaque markers to facilitate completion by an endovascular approach. It is suitable for either the elephant trunk or can also be used for a frozen elephant trunk with a separate stent in the descending aorta. The Thoraflex graft is very similar to the Siena graft but uses a frozen elephant trunk technology. The E-Vita graft is a tubular graft with a frozen elephant trunk component with a small skirt. This graft can be useful if one plans on performing an island type arch replacement. The alternative to these grafts, if one does not have access to them, would be to perform a total arch using standard tubular grafts and branch grafts to each separate head vessels. This approach obviously is very versatile but requires more time for anastomoses and requires meticulous tailoring of grafts in order to avoid kinking. More recently, a new graft, the AMDS graft, has been made available to surgeons in Canada. This graft is a bare metal stent that the surgeon must incorporate to the distal aortic anastomosis. The aim of this graft is to reduce malperfusion, reduce reentry at the distal aortic anastomosis, and to potentially induce a favorable aortic arch remodeling. The distal anastomosis should not be beveled, as the cuff on this graft is circular and not beveled. One must keep in mind that using this graft is not a substitute for resecting the primary entry tear. Therefore, for this case, what we did was a 2-vessel arch replacement using the Siena graft. Now that we've performed the distal work, clamped the graft, and are rewarming, we continue with the inspection of the root. So what we find is the following. So the dissection does go into the root, but there's no tear and the leaflets look healthy. So the next question is, what do you do with the root? Following are the indications to replace the sinuses. I think the strongest indication is the intimal tear in the root. Other indications that are more relative, from my point of view, are an aneurysmal root, a patient with severe aortic regurgitation, and a patient with a suspected genetically triggered aortopathy. I don't think one can fault you on the exam for performing a Bentall in a patient that could potentially receive a valve sparing route. I think it's a plus if you're able to describe a valve sparing route, but you have to make the examiner feel that your first concern is safety. Following are the indications to replace the actual leaflets of the valve. So patient with annular aortic ectasia with severe AI, a stenotic aortic valve, and leaflets that are destroyed. Here's a nice image of an aortic valve resuspension. In cases where the dissection does involve the root, some surgeons advocate for root reinforcement in addition to aortic valve resuspension. So the guiding principle is obviously survival is goal number one. You want to be doing a safe operation that you can describe, that you can do. I would suggest staying away from valve sparing route on the exam. I don't think one would fault you for doing a Bentall. And in a case if there's a tear that's actually going into the ostia of the RCA, I would recommend ligating the proximal RCA and being liberal with a venous bypass. Now I'll discuss briefly some specific scenarios with regards to acute dissections. The first one being preoperative malperfusion. Its prevalence is about 1/3 of patients. It's got an associated mortality that is increased when compared to patients without malperfusion, and it's been shown that the mortality remains in a lot of patients despite a successful simple hemiarch repair. Therefore, there is a substantial benefit to be gained from being able to reverse this malperfusion. This German registry nicely illustrates the mortality burden associated with multi-organ malperfusion in acute dissections. Patients with preoperative malperfusion have a decreased survival at 10 years at about 50%. Using a simple hemiarch, about 50 to 80% of patients have persistent patent false lumen, which is associated with more reoperations at 10 years and even more so in young patients. Being able to cover distal reentry tears may reduce this phenomenon. One approach that has been utilized in Philadelphia is adding an TVAR that is deployed antegrade at the time of circulatory arrest, in addition to simple hemiarch. That was found to improve the survival at 5 years in patients that were in preoperative multi-organ malperfusion. The next topic is patients with advanced age. The perioperative mortality seemed to increase in patients above 80 years old, which is not very surprising, but I wouldn't use only this factor to decide on surgical candidacy, especially on the exam. The next topic is patients coming in with brain injury. It affects about 6 of patients. These patients unfortunately have worse perioperative survival, but once they're out of the hospital, their long-term survival is no different from patients without preoperative brain injury. With surgery, about 80% of patients presenting with stroke will have reversal of such brain injury, and about 74 patients coming with coma will have reversal of this brain injury, whereas there will be no reversal if surgical treatment is not offered. Therefore, there is a clear advantage of surgery there. One should keep a high index of suspicion of a genetically triggered aortopathy when treating for a patient with acute dissection, especially in patients who are younger than expected, don't have typical traditional risk factors, have positive family history, or unusual facial or physical features. Here are a couple pictures of some patients with clearly syndromic features. I would recommend you learn these, especially the features of Marfan and Loeys-Dietz syndromes for the exam. In conclusion, rapid diagnosis and safe and expedited surgery are key to a favorable outcome in patients coming with acute type A dissections. When reviewing for the Royal College, I would highly suggest that you read these following articles. Thank you, and I hope this presentation will help you in your preparation for the Royal College exam.